This is Chapter 13, Principles of Patient Assessment. Here are the objectives for Chapter 13. Alright, so what you're going to learn in this chapter is that a thorough patient assessment will really be the foundation for the care of all of your patients. So you're going to learn how to assess your patients based on whether they are a trauma patient or a medical patient. All right, so EMRs, we are trained to identify, prioritize, and care for major signs and symptoms that the patient is displaying. We are not trying to diagnose a patient's specific problems. We're really just trying to find things that are abnormal and need attention. So we're treating those things. All right, so the assessment-based care, these are going to be 4 components of patient assessment. So the first one is scene size up. You're going to see that term a lot in the next couple of slides. So scene size up is basically just a visual overview of the scene to identify possible or various obvious hazards. Then you perform the primary assessment. So during the primary assessment, you're assessing ABCs, airway, breathing, and circulation, and bleeding as well, and you're detecting and correcting any immediate life-threatening problems during this assessment. So for example, if your patient did not have a pulse, you would begin CPR. And then the secondary assessment, this is more about obtaining medical history of that patient and then performing a physical exam. And then during reassessment, you are taking vitals, you are repeating the primary assessment to reassess the ABCs, and you're also going to reevaluate and adjust any interventions as needed. So we're really going to look at these 4 components and kind of break them down during this chapter. All right, so scene safety. Scene safety is the first thing that you do whenever you enter the scene. So you are assessing the scene to make sure that it is not dangerous to you, that the scene is safe. So this allows rescuers to access and provide care to patients without putting themselves in danger. So think of it as like you cannot care for that patient if you get injured yourself because the scene was unsafe. So an unsafe scene contains any hazards that are immediate or potential. Okay, so this patient assessment algorithm, this is in your textbook or on your online book. This is just giving you an idea of what we are going to be talking about today. As far as if the scene is safe, if the scene is unsafe, what is your next step? And then it also goes through whether the patient is a trauma patient or medical patient, if they have a significant MOI or not significant, or from the medical perspective, if they're stable or unstable, what you would do. So we're really going to be focusing on this a lot and breaking this down. Okay, so you have 4 types of patients. You have a responsive medical patient. You have unresponsive medical patient. So medical is where the patient has or they're describing symptoms of an illness. Then you have trauma patients with or without a significant MOI. So MOI stands for mechanism of injury. And these patients have a physical injury that was caused by an external force. And we'll talk a little bit more later about significant MOI and unsignificant and what that means. All right, so during your primary assessment, this is where you are detecting and correcting any life-threatening problems for that patient. So for the responsive medical patient, you're going to always perform the scene size up first. And during that scene size up, you're going to establish the chief complaint of that patient. So because they're responsive, they should be able to tell you, like what they're complaining of. So this would be the reason that EMS was called. Then you perform the primary assessment. So you are assessing airway, breathing, circulation, ABCs, check for bleeding. If there are any immediate life threats, you treat those immediately. After you have treated those, you are going to obtain a medical history from that patient, or you can get it from like a caregiver or a bystander if their family. And then you're going to perform a secondary assessment, which includes obtaining vital signs. All right, so this picture is just showing an example of performing a scene size up and then a way to establish the chief complaint. So you would just get that from the patient. Then you would perform a primary assessment, caring for any immediate and life-threatening injuries. Then obtain a medical history, trying to find out, has this happened before? Are you on any medications? And then you're going to perform a secondary assessment, which includes taking vital signs. Okay, so for an unresponsive medical patient, again, we always start with the scene size up. That's what we do first. So once the scene is safe, we enter the scene and we perform the primary assessment, so assessing our ABCs. And because the patient is unresponsive, we are going to perform a rapid secondary assessment. So this is what we're doing to identify any signs of illness. You're going to obtain the baseline vital signs. So remember, that is the first set of vitals that you take, and then you will perform a reassessment. So this would be the scene size up. This would be performing a primary assessment, caring for any immediate life-threatening injuries, and then perform a rapid secondary assessment to identify signs of illness. So this would be when you are obtaining baseline vitals and then performing any reassessments as needed. Okay, so for a trauma patient who has no significant mechanism of injury, so mechanism of injury stands for, it is another abbreviation is MOI. So this would be, you perform the scene size up, you would perform a primary assessment. So you're going to see those two are what you do for like every single patient, no matter what. Primary assessment. Once you have treated those, you are performing a focused secondary assessment based on the patient's injuries, and then you're going to reassess. So this is showing the scene size up. This is showing performing a primary assessment, caring for immediate life threats first. And then after the primary assessment, you perform a focused secondary assessment based on the patient's injuries. All right, for the trauma patient with a significant MOI, scene size up, primary assessment, you're going to perform a rapid secondary assessment where you're obtaining baseline vitals and then reassess. So here would be our scene size up, performing the primary assessment, caring for any immediate life threats, and then perform a rapid secondary assessment. Okay, this picture is really just to show you that sometimes the patient's chief complaint may not always be like super obvious as you approach. So that is why it's important to know how to interview a patient, the right questions to ask, because it may not be obvious like it was in the previous pictures. Okay, so now we're going to break down the scene size up. So safety is the number one goal for yourself as an EMR. So your primary, most important thing that you do is keeping yourself safe. So this is going to begin with the information that you receive from dispatch about the call and what dispatch really knows about the patient. So the first thing that we do is we are taking BSI precautions. So to protect you and to protect the patient, we always wear gloves. Gloves is the minimum BSI that we wear. Eye protection if needed. And then you're going to wear your PPE, your personal protective equipment. All right, then during the scene size up, you're going to identify the MOI, or the nature of illness. So MOI stands for mechanism of injury. So these are combined forces that caused the injury. So questions that you're kind of like asking yourself would be like, does it look like the patient fell? Do they have a penetrating wound? Were they in a motor vehicle crash? You can also get this information from bystanders as well. Then the nature of illness is the NOI. So this would be for our medical patients. What is medically wrong with that patient? The complaint that's not related to an injury. So some questions that you can kind of ask yourself to try to figure out what the NOI is. You can see if the patient is holding their chest or abdomen like they're in pain. Are they in a position that maybe suggests that they're in pain or they're uncomfortable? Once you have figured out the MOI, or nature of illness, you are going to determine the number of patients, and based on that number, that's going to help you determine any additional resources that you may need. So if you have more than one patient, if you have several patients that need to be transported, you're going to need more than one ambulance. So you're going to have to call for backup to get those. Another example of additional resources would be if you have an overweight patient who needs to be brought downstairs, you're probably not going to be able to, lift and carry that patient by yourself, right? So you would probably need additional people to help you out with that. Other resources would be like if the patient needed to be transported by like air transport or helicopter to a trauma facility. Those would be additional resources. And then consider the need for spinal precautions. So if they have a suspected spinal injury based on the mechanism of injury, you would take care of that. Okay, so here's an example of what you would encounter for the scene size up for a trauma patient. So sometimes your trauma patient may not be responsive. So just based on how you see them whenever you enter the scene, you're kind of putting the pieces together to try to figure out what their mechanism of injury was. So obviously this would be, he was up on this ladder and fell. All right, and then for a medical patient, the nature of illness, you can always ask the patient for their chief complaint. And that will give you a better idea. Okay, so for scene safety, remember we never assume that the scene is safe. Things that can make the scene unsafe would be vehicle collisions, traffic, release of toxic substances or chemicals, violence or crime, any weapon or any unsafe surface would make the scene unsafe. Okay, so once you get to your patient's side, remember you introduce yourself, tell them your name, and then you're going to tell them your level of training, so let them know that you're a trained EMR. And then remember you do have to get consent from that patient to provide care for them. Okay, so for the primary assessment is really going to be designed to help you detect or correct any immediate life threats. So that would be threats to the airway, breathing, circulation, or bleeding. All right, so this is a scene size up, and this is where you're performing, you're gaining like a general impression of that patient. This is where you would evaluate the mental status of that patient. Then you address any issues relating to the airway, breathing, and circulation. And then determine patient priority for transport. So we'll go over each of those. All right, so you're going to form a general impression of your patient. Your general impression is just what's going to help you determine the seriousness of the patient's condition based on their level of distress and their mental status. So whenever you are getting your impression, you're trying to figure out if they're not responsive, try to figure out their age, their gender, and then their level of distress or responsiveness. So, for example, like it would be, I have a 30-year-old male who is in moderate distress, or I have a 60-year-old female who appears unresponsive. So you would assess the patient's mental status during the primary assessment. You're going to assess the patient's airway, their breathing, circulation, and assess any uncontrolled bleeding, and then make a decision on priority or urgency for transport. So again, that general impression is your first informal assessment of the patient's overall condition based on their level of distress or responsiveness. And then the ABCs, you're going to hear that a lot throughout this course. That stands for airway, breathing, and circulation. So we always assess the ABCs during the primary assessment. All right, so this is another example of seeing size up and then forming a general impression of the patient. So you assess the patient's mental status by trying to get a response. And then you would assess their airway, breathing, and circulation. And then you're going to determine patient priority for transport. Okay, so AVPU, this should look familiar from Chapter 12. So whenever you are trying to determine a level of responsiveness, you're going to use the AVPU scale. Remember, A stands for alert, V is verbal, P is painful, and U is unresponsive. All right, so this is a first responder checking for responsiveness, basically trying to determine is the patient stable or unstable. Ensuring an open airway and adequate breathing. Checking for the presence of a pulse. And then looking for and controlling all major bleeding. Okay, so as far as mental status goes, if your patient is unresponsive, you may need to reposition them to check for breathing, pulse, serious bleeding, or perform CPR. So if they were like in the prone position and you needed to perform CPR, you would obviously have to put them in the supine position. Okay, if the patient is unresponsive and breathing, there will be a pulse. If they are not breathing, you're going to check the carotid pulse on the neck. And the pulse at the wrist, which is your radial pulse, it may not be present if the patient is in shock. So here on the left, they're checking for carotid pulse. And then here on the right, they are checking for radial. All right, so remember, if there is no pulse, we are immediately alerting dispatch and you are starting CPR immediately. If they are not breathing, but they do have a pulse, they may have an airway obstruction or they may be in respiratory arrest. Okay, along with the ABCs, you are checking for bleeding, for serious bleeding. So if the blood is bright red and it is spurting, it's coming from an artery. So every time that the heart pumps out blood, that is when the blood is going to be spurting. So if it's bright red and spurting, that is going to be an arterial bleed. This can be life-threatening if not controlled, because the patient is losing really large amounts of blood in a short period of time. If it is dark red and it is oozing, it is going to be coming from a vein. So venous bleeds, they can be life-threatening if the patient has been bleeding for a long time, but typically venous bleeds are going to be easier to control than an arterial bleed. The main concern really isn't going to be the type of bleeding, it's going to be like the total amount of blood loss for that patient. That is what is concerning. So obviously you would attempt to control the bleeding. Okay, these are going to be some examples of high priority patients that need to be transported immediately. If the patient is unresponsive, if they are having difficulty breathing, if they have any severe bleeding or shock, a complicated childbirth, that would be like if the baby is being born breech, if the umbilical cord is presenting first. You'll learn a little bit more about that in the childbirth chapter. If they are having chest pain or any severe pain, they are considered high priority patients. Okay, let's talk a little bit about infants and children. So children are not little adults, so you're not going to treat them as such. So remember, they are going to be shy and they're probably not going to trust strangers. So if they have a parent that is present, it's usually best to assess them with them like sitting on the parent's lap. If you have to open the airway, you open it with the head in the neutral position. The breathing and the pulse rates, remember those are going to be faster for infants and children. And then we check the brachial pulse in the infant and the small child. Circulation, we're going to check capillary refill for that. Remember, blood pressure is not a good indication of if a child or infant is going into shock. And then their condition can change very, very quickly. So this is a picture to show you where to check the brachial pulse. Okay. Whenever you are getting an update on or updating someone on the patient's condition, you are going to talk about the mental status of that patient. Are they alert? Are they verbal? Are they unresponsive? The age, if you don't know the age, you just kind of guess. The sex of that patient, the chief complaint, their airway, breathing, and circulation status, and any interventions that you perform. Did you control bleeding? Did you put them on oxygen? Did you give them a certain type of medication? And then the results of those interventions. Okay, so now we're going to move on to the secondary assessment. So think of the primary assessment as treating those life-threatening injuries. So once we treat those and they are under control, we can move on to the secondary assessment. So the secondary assessment is really where you are going to care for specific injuries or medical problems. So this is where our sample acronym kind of comes into play. So you're going to get a patient history. You're going to perform either a rapid or a focused secondary assessment based on the patient's condition. And we'll talk about that in a little bit. You're getting vital signs, and then you are asking for symptoms from that patient, and then you're looking for signs. All right, so remember, for our objective findings are going to be signs. These are things that we can see, we can feel, measure. These are facts. So this would be like blood pressure, pulse rate. Subjective findings are going to be opinions and influenced by someone. So this is typically what the patient is telling you, like how they're feeling. They feel dizzy, they feel nauseous. Okay, so before we start going over the MOIs, sometimes you may not actually get to the secondary assessment. Okay, so you're not necessarily going to be doing this for every patient. So an example would be if you're giving CPR, you may not actually get to that secondary assessment if they still don't have a pulse. So you're not always going to be performing a secondary assessment if you still have those life-threatening injuries or situations. Okay, so for a trauma patient that has no significant MOI, so this basically means that they have a low probability of a life-threatening injury. You're going to examine the area that the patient tells you is injured. You're going to obtain baseline vitals, gather their patient history, and then provide appropriate care for that injury. So that's no significant mechanism of injury. All right, so this is where we would examine the patient, the area that the patient is telling you is injured. You're getting your baseline vitals, gathering a patient history. If the patient is unable to answer the questions, remember you can ask a bystander or a family member for that patient history. And then provide appropriate care for the injury. Okay, so significant mechanism of injury, this means that they have a high probability of a life-threatening injury. For adults, MOIs that are considered significant would be an ejection from a vehicle. So like the patient wasn't wearing their seatbelt and they were ejected from the vehicle. Death of one or more passengers in the motor vehicle crash. A fall from greater than 15 feet. A rollover vehicle collision. High-speed vehicle collision. A vehicle that hits a pedestrian. Motorcycle crash. Unresponsiveness. Altered mental status. Penetrations of the head, neck, chest, and abdomen. So all of those are considered significant MOIs for adults. Now for children, a significant MOI would be falls of more than 10 feet, bicycle collision, or medium speed vehicle collision. Okay, so for the rapid secondary assessment, if they have a significant MOI or they are an unresponsive medical patient, you're going to stabilize the patient's head and neck. You're going to palpate the head, the face, and the neck and apply a cervical collar if needed or if appropriate. And you're going to palpate the chest, each quadrant of the abdomen, the pelvis, back, and extremities. Go through the legs first and then the arms. All right, so this is just showing you pictures of each of those that we just went over. So you're stabilizing the patient's head and neck. You're going to palpate the neck and apply a seat collar if needed. This shows palpating the chest, palpating each quadrant of the abdomen, palpating the pelvis, palpating the back. You're just going to slide your hands underneath the patient's back to check for any bleeding, and then palpate all four extremities. All right, so the rapid secondary assessment, this should be a quick head-to-toe assessment of the most critical patients. So this should really take no more than 90 seconds. When you're interviewing the alert patient, questions that you would ask them, what is your name? Can you tell me how old you are? What's going on today? How did this happen? And then how long have you felt this way? Has this sort of thing happened before? Are there any current medical problems that you're having? Are you taking any medications? Do you have any allergies? When was your last oral intake? So these questions should look familiar. These are the sample questions, right? So you're looking for signs and symptoms, allergies, medications, past medical history, last oral intake, and any events leading to that illness or injury. All right, so this is a picture of gathering a patient history, performing a focused secondary assessment based on the patient's chief complaint, getting those vital signs, and then providing the appropriate care as needed. So remember, for unresponsive patients, you can interview bystanders, ask if they know the patient's name, ask if they saw what happened, is there anything else that's important that you saw? Did they complain of anything before this happened? Like, did they complain of like chest pain? Did they complain of feeling nauseous? Did they have any known illnesses or problems? Do you know if they take any medications? So here's just a picture of how you would ask the bystanders those questions. All right, also during the secondary assessment, you're looking to see if the patient has any medical identification or jewelry. This could be a necklace or a bracelet that's identifying any type of medical issue. And then you're getting that first set of vital signs, which is called the baseline vitals. This is pulse, respiration, skin signs, and then you're assessing pupils. So you're also going to take additional vitals at regular intervals. This helps to determine if the patient is getting better, if they're getting worse, or if they're staying the same. So usually if it is a patient who is like in critical care, we're usually going to assess every 5 minutes. If the patient is considered stable and not critical, it's usually going to be every 15. All right, during the physical exam, if they are responsive, you're performing the focused secondary assessment based on the chief complaint. And if they're unresponsive, you're conducting the rapid secondary assessment of the entire body. Okay. So BP Doc is another tool that helps us remember what to look for in a trauma patient whenever you are doing a physical assessment. So as we're doing that physical assessment, we're looking for bleeding, for pain, deformities, any open wounds, and crepitus. So crepitus is a noise or a sensation. It's like a grating sound that occurs whenever broken bone ends are rubbed together. All right, and then here is another tool: deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. We're also looking for these as well during the secondary assessment. Okay, so we're going to spend a good bit of time talking about, whenever you are assessing during your secondary assessment, the part of the body that you're looking at, and then like specifically what you're looking for. So whenever you're checking the head, you're checking for bleeding and you're checking for deformities. So you're going to have your gloves, you're going to use your hands and your fingers to kind of rub through the hair, and then look at your gloves to see if there's any blood on your gloves. You're going to check the face for any pain or discoloration or deformities. And then you're checking to see if you see any fluid that's leaking out of the ears, the nose, or the mouth. When you're examining the eyes, you're checking for signs of injuries. So you're going to check the pupils to see if they are pearl. And then you're also going to check the inner surface of the eyelid. So that should be moist and it should be pink. If it is not, if it's like a very pale color, that means that the patient probably has poor perfusion. When you're inspecting the nose and the ears, you're looking for drainage, specifically any clear or bloody fluids. If you see that, that could indicate that they have a skull fracture. And then you're also looking for flaring nostrils whenever they are breathing. That can indicate respiratory distress. All right, for the mouth, we're looking for any foreign material, any bleeding, any tissue damage. You're also looking for things like broken teeth, dentures, crowns, bridges, food, or vomit, anything that could obstruct that airway. Okay. So this is showing you how to palpate the head and inspect the head with gloves. This is showing how to check for pupils, so you're checking for equality and reaction to light. This is how you would inspect the mouth for anything that would cause an airway obstruction. Inspecting the neck for any pain and deformities. Palpating the chest. Okay. So whenever you are... Did I skip one? Sorry, hang on. Yeah, it skipped on me. Sorry. Okay. So whenever you are checking the neck and the back, you're checking for pain and deformity. So you're looking for any medical identification. You're making sure that the patient does not have a stoma. You're also going to check for something called tracheal deviation. So tracheal deviation is where the trachea shifts from the midline to like one side or the other. It occurs when there's a buildup of pressure inside of the chest. So the term tension pneumothorax can cause tracheal deviation. You're also looking for JVD, which stands for jugular vein distension. That is just the abnormal bulging of the veins on the side of the neck. That can mean that, they have a chest injury, or it could be a sign of cardiac compromise. And then you're also looking for accessory muscle use. All right, the hands on the chest. So you're going to inspect the chest. You're obviously going to check for the sides for like pain and deformities, but you're going to put both hands on top of the chest, and you're going to check for equal expansion. So if you see paradoxical movement, which is basically like whenever they breathe, like one side does not rise, or it looks like one side is maybe like floating, that can be a sign of flail chest. So any portion that floats in the opposite direction is obviously not normal. Okay, we're going to go through these because we already went through those. So this is how you would assess the chest. Okay. So for the abdomen, you're going to inspect the abdomen for any trauma. So you're checking for pain, deformity, distension. Is it rigid? Is the patient guarding that abdominal area? Like when you press, do they automatically like bring their hands up to their abdomen? And so you're going to assess the 4 abdominal quadrants when you do that. When you assess the pelvis, you are checking for injury to the genital area, any loss of bladder control. Are they bleeding in that area? And then you're also checking for priapism in males. For the leg and the foot, you are really just going to compare like one leg and one foot to another, and you're comparing the length, you're comparing the shape, and if there's any deformity as well. And you're also, when you get to the foot, you're also going to check the pulse on top of the foot to make sure that there is a pulse. So that's a way to assess circulation. Then for the upper extremities, you are really doing the same thing. and you are assessing pain and deformity, and then comparing length, shape, and deformity as well. And then you're also going to check circulation, sensation, and motor function in each of the hands. So you're checking for weakness, numbness, or tingling. One of the ways that you would assess that is you're obviously going to check pulse, so you would check a radial pulse. You would ask them, can they wiggle their fingers? And you would kind of like tap their fingers and ask, hey, can you feel this? Whenever you're assessing the hands, you're also going to look to see if you see something called track marks. So track marks are small dots of infection, scarring, or bruising, and typically they run along a vein. This can be a sign of IV drug abuse. So if you see that, that's just something to keep in mind. Okay, so this is showing the EMR palpating the 4 quadrants for pain and deformity. This is showing how to palpate the pelvis. This is palpating the lower back for any pain or deformity. Now, when appropriate, you can roll the patient, do a log roll of the patient to inspect the entire back. Palpating the legs and feet for pain, deformity, and for crepitus. Assessing circulation, sensation, and motor function in each foot. Palpating the arms and hands for pain, deformity, and crepitus. And then assessing that circulation, sensation, and motor function in each hand. Okay, so some other, another acronym that you should be familiar with from Chapter 12 is OPQRST. This is another tool that we use to just help you ask certain questions of that patient who is having, excuse me, who is a stable patient. They're able to answer your questions. Okay, so remember O stands for onset. So a question that you would ask would be like, what were you doing when this first started happening? P stands for provocation. So does anything make it better or worse? Q stands for quality. Can you describe what your pain feels like? Is it sharp? Is it dull? R stands for region or radiate. Can you point with one finger to where the pain is worse? Does it go anywhere else? S is severity. So on a scale of 1 to 10, can you rate your pain? T is time. How long have you had this pain, or when did you start feeling the pain? Okay, and then the last component is reassessment. So you would repeat the primary assessment, which includes making sure that the ABCs are still good to go. Obviously, if they are not, if there are changes in the status of the ABCs, you would have to address that. Reassess the vital signs. So if you're checking vitals every 5 minutes, you're comparing those with the baseline vitals to determine, is that patient's status, are they getting better? Is it getting worse? Or are they staying the same? You're going to check and adjust any interventions as appropriate, hand off to the EMTs, and then you're going to give the EMTs a verbal report of basically everything that you did. So it would include all of this stuff right here. Okay, so just to kind of summarize all of this, so remember the 4 components of patient assessment are going to be the scene size up, right? It's going to be the primary assessment. So the primary assessment is where you're assessing those ABCs and bleeding, and you're detecting and correcting any immediate life-threatening problems or injuries. Then, once those have been taken care of, you move on to the secondary assessment. So that is where you're getting a medical history and performing a physical exam. And then reassessment includes reassessing vital signs, comparing those vital signs to the baseline vitals, repeating your primary assessment, and evaluating and adjusting any interventions needed. So that would be like if you controlled bleeding, making sure that the bleeding is still controlled. If you put them on oxygen, assessing that. And then giving the verbal report. Okay, that is the end of Chapter 13, Patient Assessment.